So, why go over the complete trial when you already know the results? One of the major reasons for this, I want to take you through the journey and the story of somebody who has been an insider, and because I was personally involved in the trial. So it's interesting when you live through the story of the trial yourself, and you really go through the pros and cons of being involved in a major international randomized controlled trial. And it's important to put it in the context as well of other trials, such as the recent ischemia trials and others. And lastly, the issue of timing. There have been a question yesterday of when to open the non-culprit vessel. Is it better to do it during hospitalization or after hospitalization? So as you know, the complete trial was a randomized comparative effectiveness study of complete versus culprit-only revascularization strategies to treat multivessel disease after early PCI for STEMI. And the results already published in the New England Journal of Medicine. There have been multiple committees. I was honored to be part of the International Steering Committee. These are the disclosures. The complete was funded by the Canadian Institutes for Health Research and the PHRI from McMaster with grants from these bodies. So the background, patients undergoing primary PCI to the culprit lesion for STEMI are often found to have multivessel disease. 30 to 50% of STEMI have multivessel disease. And it's uncertain what to do, routinely vascularize them with PCI or manage them conservatively. And prior RCTs have shown non-culprit lesion PCI reduces revascularization, but none were powered to detect moderate reductions in hard outcomes. Meta-analyses have suggested a possible reduction in cardiovascular death or MI, but this result is fragile and no single randomized controlled trial has been adequately powered to confirm this, and the complete was set up to address this evidence gap. You're all aware of these many trials, PRAMI and culprit, DINAMI, and what have you, and you can see the sample size on the right side here, very small numbers that really to confirm improvement in, although positive in many of them, not sure whether to really take much out of the final results. To show this, for example, this graph show on the upper side here favoring multivessel PCI and down favoring culprit-only PCI, and these are the trials. And you can see here the results are positive if they go up as favoring multivessel PCI. But to not to make it complicated, to make it simple, is basically in order to adjust for the biases and multiple differences among these trials, this line has to go up all the way to meet the trial sequential boundary, meaning that it is positive overall in terms of reducing outcome. So slightly positive, but smaller trials small trials, and the results are very fragile. The primary objective, as we mentioned, is to determine whether a strategy of routine staged non-culprit PCI with the goal of complete revascularization is superior to a strategy of culprit lesion only PCI in the reducing hard outcomes. This is the schematic of the design of the trial. So randomization was done in 2016 patients in complete revascularization and 2025 to culprit lesion only revascularization. And as you can see, it is a very pragmatic trial. The exclusion is intention to revascularize non-culprit lesion, planned surgical revascularization of prior CABG. So very practical and very pragmatic trial, trying to avoid basically a lot of limitations of randomized trials and trying to be very generalizable to our patients. And using guidelines, guidelines-directed medical therapy, such as aspirin, ticagrelor, highly recommended in addition to other therapies. Median follow-up of 3 years now. It's important to mention the primary outcome. It was originally death or cardiovascular death or new MI. The steering committee has to amend the protocol a few months before and to add another co-primary endpoint of cardiovascular death, new MI, or ischemia-driven revascularization, in order to assess whether the ischemia-driven revascularization will really make sure that we're assessing all important outcomes in the primary events. These are the secondary key secondary outcomes. These are the global recruitments, 140 centers, 31 countries. From the Middle East, 55 patients have been recruited. I have to say, unfortunately, many centers in the region declined to join the study, as was basically felt by many people to be a tough study to get into, as many people basically their assessment is that we're going to open these vessels anyway, so there's no point in getting into this randomized trial. I have to say, heads up to Canada, was basically followed by United Kingdom, because they are the highest recruiting in the randomized trial. This is quickly the study power and follow-up. The study period, 2013 to 2017, there was an angiographic core lab, and it was intention to treat. Very important to see the follow-up. So 99.1% and 99.3%, so excellent follow-up. And the crossover was very small, around 4%. These are the baseline characteristics. The average age is around 60, 61, 62, slightly older than our STEMI patients in the Gulf, around 54, 52 in our region. Diabetes is 19%, in our region is around 25% in ACS patients. And these are the rest of the medications and the treatments, excellent treatment percentages. These are the way the angiograph looked like. Notice the radial axis around 81%, so excellent radial axis percentages. These are the non-culprit lesions. The left main 0.4%, LAD represented 38 versus 41%. Proximal LAD was around 10%. And on the right side, it shows you the stenosis. So we're talking about very severe lesions. FFR, importantly, was used only in less than 1%, understandably, because basically the criteria for including the patients was basically very tight lesions. Complete revascularization was achieved in 90%. These are the results. First, co-primary outcome, cardiovascular death or new MI, was positive for complete revascularization. And the second co-primary outcome, adding ischemia-driven revascularization, was even more pronounced to be in the complete revascularization arm. These are shown in the table here, including the key secondary outcomes, and the including myocardial infarction to be positive, and ischemia-driven revascularization and unstable angina. These are the subtypes of MIs. Basically, what kind of MIs? We'll talk about non-STEMI in 3.2% and STEMI in 2.1%. Most of them are type 1 MIs. So we'll talk about Gen 1 MIs. No safety issues in terms of between the two arms, and only 7 patients in those who got the revascularization within the hospital got the acute kidney injury. This is just released online, and will December 3rd, timing of stage non-culprit PCI led by David Wood, and basically it shows that whether you do the revascularization within the index hospitalization or after hospital discharge, it was positive either way. The median time in the index hospitalization was 1 day, and the median days for after discharge was 23 days. So you're okay either way to stage the PCI for the other vessels, either within the same hospitalization or after discharge. And it was even more pronounced if you add the ischemia-driven revascularization. So you get more benefit, even so, with the ischemia-driven revascularization compared to the two groups. When it comes to the landmark analysis, if you actually do the analysis only, randomization to 45 days, and after 45 days to study endpoint, most of the benefits happen after 45 days. So you get more benefit on the long run after 45 days. And it's more so if you involve the ischemia-driven revascularization. So the conclusion of the study published in JACC, among STEMI patients with multivessel disease, the benefit of complete revascularization over culprit lesion only PCI was consistent irrespective of the investigator-determined timing. So remember this JACC paper, the sub-study timing from complete was not, the timing part was not randomized. It was based on the intention of the investigator to really revascularize or not within hospitalization or after hospital discharge. So you have to take this with this cautious note. So this is complete compared to other previous trials, the PRAMI, culprit, and TENAMI, and compare acute and others. Basically complete 4,041 patients. Basically more than all these results, all these trials combined. And FFR, it's importantly mentioned, used on only less than 1% of the cases. And you can see here the comparison between the different trials. And I will finish with this, is basically this editorial that the complete revascularization in STEMI is a classic story of the maturation of the evidence base that in turn influences radical changes in clinical decision making, from registry studies that indicate harm to medium-sized randomized trials suggesting benefits in composite outcomes, to a large, adequately powered randomized trial confirming reduction in important hard clinical endpoints. But I have one. So going all the way from class 3, as suggested by some registries, to do non-culprit, to class 2B, to class 2A, even to maybe class 1, as my prediction. I predict in the future guidelines. So in conclusion, in patients with STEMI and multivessel disease, compared with culprit lesion only PCI, routine non-culprit lesion PCI with a goal of complete revascularization resulted in these impressive reductions in cardiovascular death or new MI, and even more so by almost 50% if you include ischemia-driven revascularization. And the benefit of complete revascularization was similar in those undergoing non-culprit lesion PCI during the index hospitalization, median 1 day, and several weeks after hospital discharge, median 3 weeks. And the benefit of complete revascularization and hard outcomes emergence mainly over the long term, more than 45 days, and there was no significant difference in bleeding, stent thrombosis, acute kidney injury, or stroke. It will be interesting to discuss with the panel and the audience, how do you put this in the context of the other trial, the ischemia trial, which was done in stable patients, opening stable lesions. Thank you very much for your kind attention.